So delighted to welcome you to another MCHRI seminar. This is promoting our partnership with the Biodesign Faculty Fellows program here at Stanford. We call this Designing Innovations to Improve Health and Healthcare, but as folks who aren't familiar with biodesign, there's many opportunities to engage within the program, and this faculty fellowship is really a wonderful addition to their portfolio that offers our faculty a great way to learn the biodesign process, think about new solutions or unmet needs, and just the unique process that they've iterated upon for the last few years. And delighted to be joined by colleagues Anu, Sumit, and Golara, who are going to showcase some of the work that they've been up to. But first, just want to showcase some of the upcoming events that are going on within MCHRI if you're not familiar or want to get connected. So first, just want to thank our colleagues in our education committee. We really can't promote these seminars without their support and their ideas, and just shown there. We've got an upcoming seminar that's also equally interesting for those that are interested in health technologies and health innovations, featuring some digital imaging and monitoring for skin diseases, featuring Jean Tang, Eleni, and Roxana. And then another interesting session as part of our maternal month, focused on iron deficiency and anemia in pregnancy, featuring our colleagues there. And then self-promotion, I'll be supporting our colleagues who are focused on innovation at the end of this month for office hours. Feel free to reach out to me for any areas there, and hope you're able to join. We have a great faculty training resource page that we've just discovered and are promoting. Really a whole host of opportunities that are there. I'm going to pause just for a minute as it's a lot to take on in case you're interested, but really key in on the faculty training URL there. It probably provides more information for you to take advantage of. And then plug for the save the date, our symposium, our 6th annual symposium is coming up on October 19th. It'll again be in person. We're really excited about that. Hosted at LKSC as it has always been. So again, without further ado, and so sorry for the technical difficulties I experienced, really delighted to host today's seminar. Please feel free to use the Q&A to pose questions while the discussion is going, but I will pass it over to Koen Chef, who is the director of the Biodesign Faculty Fellows Program, and can just provide you an overview of the program before we dig into the individual topics. So without further ado, Koen.
Thank you, Grant. So first of all, I'll say that MCHRI has been wonderful in supporting our Biodesign Faculty Fellowship. I myself was previously a faculty fellow as well, supported by MCHRI when I first came here to Stanford. So we really appreciate their support and continued support as we've gone on. So without further ado, I just wanted to briefly talk a bit about the Biodesign Faculty Fellowship. We are, sorry, I'm just trying to get the presenter mode here shared. We are currently in recruiting season, and we actually just had applications open last week, and we'll have a full in-depth information session this coming Wednesday over at the Clark Center, and applications will be due on April 28th. So this is our goal today, is to give you a little bit of taste and background about the fellowship, and then give you guys a chance to hear about some of our pediatric and maternal health focused fellows from past years and what they have done. So overall, the goal of biodesign is to advance health outcomes and equity through innovation, education, translation, and policy. And so we have a lot of components in our collaboration, empathy, integrity, diversity, innovation, and leadership. And the Biodesign Faculty Fellowship is one component of many of the training programs, as you'll see. I wanted to really point this out because I think it's of utmost importance in MCHRI especially. And that's that the diversity is that we believe in that across multiple dimensions, both in the components of our program, but also in the populations that we are serving. And so we're very much inclined and thoughtful of serving underserved populations. We always see the pediatric population, the maternal population, the fetal population in that. And so I just wanted to point that out, that is becoming a growing focus and of utmost importance for the BFF program. With regards to the BFF program, it was really designed to fulfill an unmet training need. Essentially, we had many training programs in biodesign at the undergraduate level, at the graduate level, postdoc, we have executive education and global programs. But what we realized was that we were really missing any kind of training for the faculty to focus on the clinical needs finding and the entire biodesign process. And that is how the faculty fellowship came to be about. It seems to be. So from biodesign, just as a whole, I really wanted to highlight that we've had 56 companies created. And I think of it's really exciting is just recently 2 companies that are focused on the pediatric and maternal population, Novinate and Emmy, were just recently acquired. And so 2 great successes from biodesign that are actually both in our underserved population arena. So I thought that that would be a great motivating factor for us to look at. Just to look at the BFF program as a whole, it runs a year long along with the normal academic year. So the fall quarter is somewhat lighter. It's a few sessions, 1 a month in October, November, December, and it's to kick off the process in October, really give kind of a dedicated day focusing on all the components of the biodesign process, and then proceed through needs finding over the next few months. We then get very intense in the winter and spring quarter with weekly sessions and a lot of work in between to identify, hone in those needs, develop a concept, and screen those concepts to find the best solution once we've really ironed out the need. So one thing, just to clarify, this involves faculty from both the School of Medicine and the engineering school, and it's very much focused on project-based mentorship. And so it does move at a faster pace compared to how much class there is, but that's because we're respectful of, all the many commitments that faculty have. We essentially have workshops every Wednesday from January through June. And during these workshops, there's dedicated coaching. I think this is the most valuable component, is that we're bringing in experts, business coaching, IP attorneys, regulatory, reimbursement, all of these experts that, normally I don't know how you would have access to all of that just instantaneously, and to have that right at your fingertips and the time that they all take really makes a big component of our program. The time commitment we normally say is about 10 hours per week in that Jan to May time period between readings, classwork, and also the project work to prepare for the classes. So just with that brief overview, I wanted to say that our current recruitment timeline, we do have a more in-depth information session this coming Wednesday at the Clark Center from 5:15 to 6:30. It's also available via Zoom. And ideally, if you guys can register by today, that would be great, but we welcome you guys if that's not the case as well. Applications are due at the end of the month, April 28th, and then there'll be interviews shortly after and decisions announced May 19th. This is our leadership team. So I'm one of the 3 assistant directors, and we have a team that's been very involved for some time. And I just wanted to say that if there's any more questions, happy to entertain them either today or via email, and you can always find more information on our website as well. These are just a list of all of our fellows by department, and I'm just wanted to show you this to highlight the 3 that we'll be presenting today. So with that, I will hand it over to our first BFF alum, Sumit Bhargava. Let me switch my screen share here.
All right, let me start sharing my screen. I want to thank Dr. Sheth and MCHRI for this kind invitation to present today and share some of the stuff that I've been doing for the past 4 years. So hope everyone can kind of see my screen. And so my project is entitled Pediatric Home Sleep Apnea Testing. And that is what I'm going to be talking about, essentially focusing upon my journey so far in this process. So for me, the journey in biodesign actually began with the 2018 cohort. This is me as part of this very talented group of individuals that I was very fortunate to be part of. Some of the people in this slide have continued to work on projects that have been funded by Biodesign and other external agencies. And so I really think that the Biodesign Faculty Fellowship for me was really an eye-opening introduction to a completely new way to look at unmet needs and problems in the clinical space. So why did I choose to do this project? And my journey actually started on December 18, 2018. As Dr. Sheth just mentioned, the fall cohort kind of starts in October. You have one meeting a month, October to December. So in October and November, I had finished 2 meetings and I was trying to find a need. And then on December 18th, I get this email. I'll give people a few seconds to kind of look at it. But essentially, this is from Sandy Ruggles, who people might already know or will meet if you decide to apply for the Stanford Biodesign Faculty Fellowship. And so this email led to a further discussion with Sandy, and it led to a description of my need, which is a better way to diagnose OSA in habitually snoring children at home in order to quantify the severity of OSA for surgical treatment. And so the need led to a vision for the project, which is that early diagnosis of sleep apnea to improve the health of children. Now, I've been working on this on my own and then with collaborators since I finished the project in 2018. And I wanted to give the audience a sense of how a project like this kind of proceeds. So this slide is essentially talking about the progression of funding with what I was kind of doing. And you can kind of see that I started in 2019 when the Department of Pediatrics put $7,000 towards funding my time at Biodesign. And in 2020, I got one of the first extension grants, which was a sum of $10,000. In 2021, I applied for the MCHRI Clinical Educator Grant, which was $35,000. Then I met an engineering collaborator that happened somewhere over here, which led to my application with my collaborator for Coulter, for the Coulter grant, which was $100,000. And then we also were fortunate enough to get into the Fogarty Invention Accelerator, for which really I cannot put a monetary value. That was really a priceless interaction. And then most recently, we renewed our Coulter and were lucky enough to get funding for our second year. So this is kind of a fairly typical progression through the Biodesign project. And one of the key things about this is all intramural funding. This is all funding from Stanford. This is just a slide of this great collaboration between the Fogarty Center, which is situated at El Camino Hospital, and the Bayer Center for Biodesign, which was truly transformational for my project. To give a little bit more detail about where this project is actually aimed, for a lot of projects that come out of biodesign, the need is very closely defined. In the case of my project, we wanted to kind of come up with a new solution for pediatric home sleep apnea testing that would essentially meet the triple aim of meeting the needs or the unmet needs of patients, of providers, and of payers and employers. And you see that summarized kind of in the triple aim that I sort of have over here. This is just a representation of how we kind of went about Coulter year one, about what we wanted to do And this is essentially just talking about the translational objectives that we had talked about in our initial presentation as Coulter finalists about a year and 2 months ago. As people would learn, if they do the faculty fellowship, you kind of create intellectual property and you try to protect it. And so we had some intellectual property that was generated either prior to this project or during this project. And so we kind of have some property that is already protected, other property that we hope to protect. In Coulter Year 2, this is kind of some of our post-transformational objectives. A key aspect, essentially, of every kind of device development is what is called risk reduction, on which there is really a great focus as you're kind of going through the fellowship and as you're seeking future funding, because everyone wants to know, how are you actually going to reduce the risk for your device? Why are people going to use your device? And so what you can see over here for Coulter Year 2 is really working on risk reduction. And for my final slide, I want to just show you a glimpse of the way ahead, which is this. And since I've been binge watching The Mandalorian, this is the final phrase. This is the way. It is going to be full of unexpected obstacles, but that is part of the biodesign process, as you will all learn. Thank you so much.
Thank you, Sumit. That was a sorry. BFF. It's really important to realize that BFF is something that we focus on in teaching you the path and teaching you the way. Sometimes the projects that you do in BFF become the projects that move forward. And sometimes it's essentially a understanding of the process so that you can apply it to new projects and new innovation. So without further ado, I'll move on to Anuradha Dayal, or Anu, who is a BFF this past 2 years ago, and go ahead and present for us. Thank you.
Okay, great. Thank you so much for having me. Can you see my screen?
Yes.
Okay, great. Yeah, my name is Anu Dayal. I am a assistant professor of pediatrics at Stanford, and I was a faculty fellow during the COVID time. So today I wanted to go through with how we think about the biodesign process, specifically on the needs finding and needs screening. So for me, it was during COVID, and I was actually working in an ER. And all these kids were coming in for ingestions because, right, everybody was at home and it's just like all chaos. Everyone's trying to work and do multiple things at a time. And so I realized, there's actually over 1 million calls to poison centers for kids less than 5 years old. And 92% of the time, these ingestions occur in your own home. And 80% of the time, these kids are less than 3 years old, as you can see here. And 70% of the time, these ingestions are actually our own meds, meds that belong to the parents and grandparents. And this is just an example of one of the meds, obviously a more serious one, but opioids. I'm sorry, let me go back. Oh, okay, sorry. I can't go back, but the last slide, basically for opioid ingestion, it's a bimodal distribution. So unfortunately, we see a lot of perhaps intentional ingestion of opioids in teenagers, but then the biggest other ingestion is actually for kids less than 3 years old. So this is the #2 reason why kids go to the ER. It's actually every 10 minutes, a kid is going to the ER for ingestion, which is about 52,000 ER visits and over $210 million in hospital costs. And there is a real call to action by all the major academies because over 4 billion medications are dispensed every year. So this is how I came to my needs statement. I was thinking about a way to prevent unsupervised medication exposures in children less than 5 years old in order to decrease the number of ER visits for toxic ingestion. So the next part after you find your need is about need screening. So what is currently out there about this problem and kind of going into a deep dive. So all of us know that we have child resistant packaging, but we know that child resistant does not mean child proof because kids are breaking into all of these medication bottles. The interesting thing that I found was that child-resistant packaging, it actually tests kids who are 42 to 51 months old. But as you can see from the previous slides, the kids who are ingesting meds are actually less than 3 years old. And then another thing that I found interesting is that kids who are less than 5, the amount of torque they have with 3 of their fingers trying to open up a pill bottle is actually higher than when we use 2 fingers to open the bottle ourselves. And so if kids aren't breaking to the bottles, they're actually finding them everywhere else. So we accidentally drop a pill on the ground. We put a pill in our purse or our wallet to take later. We put a pill on our nightstand, of course, medication organizers, and then otherwise they're kids and they find things everywhere. And this was a great study in JPEDS, and it showed for total ingestions of medications from child-resistant packaging, 60% were from the original bottle and 40% were removed and the kids found them somewhere else. So if you have a medication organizer, the odds are 2 to 1 that if a kid has an ingestion, they found the medication organizer, usually at a grandparent's house. And then, especially with grandparents or people with chronic disease, the meds that they're finding are really serious, right? Like kids are ingesting beta blockers and diabetes meds and seizure meds. And the ones that are they find outside of the container out, on the bedside table, those are things like ADHD meds and pain meds as well. So the real question is, this is life. How do you design for kids, right? Because kids always find something when they're unsupervised, even though we're trying to do the best we can. So we have to start with that kids are not little adults. And if we have to design something to help prevent ingestion, we have to think, what do you really want from a pediatric perspective? So first, whatever thing we made, it would have to adhere to the current child-resistant packaging criteria. It really should incorporate some unique knowledge about pediatrics, right? Like, so I learned that 3 fingers has more torque than an adult opening with 2 fingers, right? So maybe that's something to think about. And it really should automatically re-engage child resistance after every use. So if you don't put on the bottle cap, right? Like now that bottle is not childproof anymore. And then the last one I was thinking, if you are designing something for must-have, is just controlled dispensing of medication. So just like in this picture, if a kid opens it, they can grab 1 pill or they can grab 50. So making something with that in mind would be great. Then you also have to think about nice to have criteria if you're designing something new. It would be nice to have an agile design that could accommodate if you're taking a single pill or multiple pills. Easy portability. We're not always taking our medicines at home, so sometimes we put it in our purse or our suitcase, so it has to be portable, whatever solution. Secure access to multiple adult caregivers. For example, if you put a biometric on a Tylenol bottle, how many people in the house need that medicine, right? So it has to be available to multiple adults. And then it would be great if it could incorporate some sort of medication organization or reminder system. So if you look at the current landscape, these are the biggest things out there outside of the bottles themselves. We have these medication organizers. We have these fancy ones that have a lock that you have to remember. And then we have all these digital solutions for medication reminder and organizers. But really, if you look at the landscape, none of them address like the must-haves that I would like in a solution, as well as none of them address the nice-to-haves. And then, the final part before you're thinking about a solution is who are the players, right? There's 4.57 billion meds out there that have child-resistant packaging, and that includes stuff from the pharmacy and also over-the-counter analgesics. So whatever solution you have to think, the pharmacy is involved, FDA is involved for the child-resistant caps, hospitals, who's going to pay for a new solution, the cost of kids going to the ER. These are all things that we think about when we're deciding a solution. And then the next part, after you kind of think of all that, is you start to think about your concept in terms of what do you want to invent. So that's where I will leave you off. And hopefully that was a good overview of what this biodesign process begins with. Thanks.
Thank you, Anu, and you did a great job of really walking through a lot of the early parts, and honestly, the most important part, I'd say, of the biodesign process, which is finding your clinical need, finding that niche that's the oversight that has been going on in the current system, which is causing a gap. And we, yeah, it sounds super simple to come up with this, but the amount of research and understanding you have to dive into to get these key points where there's a gap, where there's an opportunity, is critical to finding a new process. And so, and innovating. And so we really hone in on that and spend a lot of time, because the premise being that once you've really ironed out your need criteria, inventing can be done. It can be done in many ways, but if you don't have that problem ironed out, then you could be going down a pathway for many years and just find that you're not making the impact you wanted. So I'll move forward to our last presenter, Golara Honari. She was a Biodesign Faculty Fellow from 2021 to 2022, and I'd love to hear more about your project as well.
Thank you. Can you hear me okay? Okay, so I hope that you can hear me. Well, thank you so much, Kunj, for the invite and the introduction. And I'm really grateful to be able to share my experience and journey and talk about some of the challenges I've been facing. So I'm a clinician and a clinical investigator, predominantly working in the field of eczema and contact dermatitis. And I'd like to start my story by a typical case of a patient that I see with a severe contact dermatitis. So this is a patient of mine who actually in her 60s, she started having this severe eczema on her hands. For 2 years, she was using different medications, different lotions, potions, and then it took her about 2 years to be seen in a contact dermatitis clinic. And she underwent a classic diagnostic test for contact dermatitis, which is called patch testing. She had a few positive reactions, including positive reaction to 2 preservatives in her hand. So, and within 2 months, by essentially avoiding those allergens and using a little bit of steroids, she was almost back to normal. And this is a success story, but it's a common story that we see. But like at least 50% of our patients do really well. And another key point for these individuals is that we cannot desensitize them. So this patient needs to actually be able to identify and avoid these allergens for the rest of their life. So with that, I'd like to say just a few words about eczema, aka dermatitis. There are different types of eczema. I will be talking about 2 most common types, which is atopic dermatitis, which is point blank the most common inflammatory skin disease. It's very common, probably 7% of adults and 7% of children. We can also have, so for atopic dermatitis, we need to have genetic predisposition. It's a multifactorial condition, but allergic contact dermatitis can happen to pretty much anybody. Multiple studies have shown that at least up to 20% of general population have one contact allergy. Oftentimes, fortunately, those are mild and people can identify it and avoid it, but probably about 10 to 11% of those individuals are going to have a hard time finding out what they're allergic to. These diseases cost billions of dollars, and they really have a high economic and quality of life impact. And I just want to throw in that contact dermatitis is actually the 2nd most common cause of occupational disability. So you can add all the billions to the cost of occupational care as well. So here's what we do. The gold standard for decades, we've been doing this patch testing. It is a very simple concept. We are looking for delayed type of hypersensitivities. Patients come to clinic for day 1. We apply a small amount of the common allergens to their skin of the back. We keep them on for 2 days, but then we have to look at the reactions because it's a cell-mediated process. The reactions take time to develop. For example, this is a patient of mine that if you look at some of her positive reactions, you were not able to identify this reaction on her 2 days. So, and it is cumbersome because we ask these patients to keep their back dry because we lose our markings. So it's a simple concept, but execution is a little bit cumbersome. And if you look at the outcome, we did some cost analysis studies here at Stanford, where we looked at payers' databases for patients who had commercial insurance. Interestingly, like people who had patch testing, we looked at the direct cost of care a year before and a year after patch testing. And you can see up to almost 50% improvement in the direct cost of care in the year following patch testing. And also quality of life wise, there are multiple studies. I put examples of one of the recent ones that even quality of life improves close to 50%. And interestingly, even in people who had negative patch testing, I know it's a small cohort, but it's been replicated in a couple other studies. So even quality of life improves. And this is probably because they get a chance to talk to, connect with a specialist. But with the same study, we also figured out only about 2% of people who would benefit from these testing have access to it. So what are the limiting factors? If you look at, so I'm part of the American Contact Dermatitis Society board, and then we have a severe concern in our society because there are a lot of dermatologists who don't want to do these testing because they are cumbersome, time consuming. Of the 12,500 practicing dermatologists, 5,000 allergists who offer this testing, probably less than 1,200 of them are doing allergy testing. An average wait time based on the survey of our society in 2018 was 1 to 5 months. And close to 30% of the members actually are really exhausted and tired by doing the testing the way we're doing it. And if you look at, so in our society, we have a find a doctor. And if you look at the Northern California, Nevada, this is the number of clinics you can get. And if you look inside the country, that's even worse than that. Like, 2 in South Dakota, it's just like really access is very limited. The other limiting factors are feasibility, commute to clinics, having the patients not to shower, and also cost of care. The cost is actually could vary significantly depending on what clinic these people go to. The worst I've seen was actually sadly from here at Stanford in 2018 until we were subject of MPR actually for almost $50,000 patch test bill. And fortunately, this is actually a patient of mine, very nice professor from Eureka. And fortunately, after that MPR, we were able to cut back our prices. But it's still a costly thing. So what can we do? And I love this quote by John Dewey, the American philosopher and educator: a problem well put is half solved. And what I'm really grateful with the Biodesign Fellowship is that I was really able to get a chance to brainstorm with amazing people with a lot of guidance to try to really get to the disease state fundamentals and really try to look into what are the current solutions, what can be offered to actually really, first of all, how can we define our need in a way that would lead to an actionable path for a solution. I know I actually showed really those beautiful diagrams of how we process, so I'm not going to take your time with that anymore. But that whole opportunity that I got, because I was dealing with this problem for a long time, but the opportunity to brainstorm and talk to really amazing minds and having that guidance to define the need was very helpful. So we narrowed down our need to a way to improve access to diagnosis of allergic contact dermatitis for patients with known chronic eczema in order to facilitate their allergen identification and management. I think there are infinite ways that this system and method can be improved. And then following that need definition, then we have been working a lot in ideation and concept generation, and we kept going back and forth between this dynamic part, because sometimes with the concept generation, we don't want to miss what we really wanted to follow with our need. And many practical points that was highly educational for me with this fellowship was that, there are a lot of things that I didn't think of as a clinician, when with the IP status, you have freedom to operate, what are the regulatory issues that you really have to start thinking about from the beginning? All the stakeholders have to be counted, physicians, patients, payers, and those are all the guidance that we get, especially as Kunj was mentioning with the second half of the fellowship that was very intense, but it was extremely educational for me. So our project, I was fortunate, we did start with a seed grant from the Biodesign extension, and we are working to address all those issues, but it is still a work in progress, and we're trying to come up with a system and method to help with both the identification and also delivery of the care. So I really want to thank you for your time with this.
Thank you, Golara. And I just wanted to say one more thing, and I'm sure you're seeing it with all of these presentations. The BFF fellowship is something that is really about how much you put in is how much you get out. And so there's a wide spectrum of what can be accomplished in the BFF program, and it's very independent learning focused in that if you take this and run with it, there's so many opportunities, so many connections that you can make both inside and outside of Stanford, then it can go very far. But it really is about what you do with the opportunities. And then one other thing I wanted to say is just to kind of point out that, there's a lot of focus right now on the need, and we do also work on solutions, and we have engineering coaches for everyone in the program as well to help you in prototyping and ideation. Some of that is lacking from today's presentation simply because IP considerations. We have to have all the filings and things in place before public disclosures. And so I just wanted to say that that's also a component of our Biodesign fellowship. It's just not as easily disclosed per se.
Thank you.
And I'll turn it over to Grant to moderate questions.
Thanks, Kunj. Thank you, everybody. This was such a wonderful presentation. Opportunities to engage with the Biodesign Faculty Fellowship Program, as well as opportunities for your own career interests. Just want to make sure folks have time to ask questions. I didn't see any come through in the Q&A, but please feel free to do so, or feel free to come off mute and ask folks questions. But we're done with the presentation component of our portion today.
Hey, Grant, this is Tony.
Hey, Tony.
Hey, great presentations, everybody. I put it in the Q&A. I don't know if you saw it, but a question for the group is in terms of the progression. What's most helpful from version 1 to 2 to 3, for example, for Dr. Bhargava? Was it patient testing, engineering consult, or just money so you had time to eventually do it? It seems like all those are probably involved, but because the progression really for all the fellows and also for people thinking about doing it is really helpful.
So I will tell you that I think from my perspective, the way that things worked out for me was that I finished the Biodesign Faculty Fellowship having defined a need. It was being able to define a need that could be stress tested, that allowed me to get funding. I was not able to find an engineering collaborator because sometimes things just don't work out. The way that I ended up with my current colleague is this was a recent faculty member in bioengineering who was presenting at a symposium called the eWare Symposium, which is sponsored by the Department of Chemistry here at Stanford. He had done work on sleep apnea. I was attending the seminar. I reached out to him, and here we are about 2 years later. So I think that from my perspective, I just kind of took advantage of the Stanford universe to be able to find the right collaborator to work with. And I think from my perspective, the way that I always thought of the faculty fellowship, initially it was just a thought experiment to me because I thought it's a cool thing to figure out, but then it turned into something else, is to kind of keep an open mind about what is the kind of engineering expertise you need and sort of start reviewing the faculty in the Department of Bioengineering and other departments to see if you can find like-minded people. I reached out to a lot of people, everyone responded, which is the good thing about this being internal and you also having an email address that ends in stanford.edu. So hopefully that is a helpful answer.
I think it's very helpful. I think a lot of us have I think under the motto that if you can imagine it, there's someone at Stanford that can help you make it real if you just are persistent enough. And there's plenty of also funding opportunities to do it. And so I really think that's a great example.
Yes, I learned that the motto of Silicon Valley is not always be hustling, it's always be grinding. So welcome to the grind, sir.
Yeah, and actually, I wanted to say a word too. I did, and as Kunj mentioned, I apologize, which I couldn't disclose much about our solution, but I got actually a lot of support from Biodesign too for the next steps. Like, I needed some help with the digital health platform and also with the engineering coach, and so they've been very supportive.
I want to say, I think that the biodesign community is something that once you're kind of enter it, once you're a part of it, it kind of stays with you throughout. And so there's just so many people you have access to. I'll tell you that even after I finished the fellowship, I would just, if I reach out to any of the consultants that came, they would talk with you just to give you advice, and even higher ups in the program like Gordon saw, meet with you and discuss, review things. And so you just have so many experts and people that are willing. In regards to follow-on funding, we've actually gone on further than just Stanford to now there's a angel investment group that is specifically for any biodesign alums, BFFs, or full-time innovation fellows, anything where they are investing in those people specifically to help with financing even after leaving the Stanford arena.
Can I ask a question?
Mm-hmm.
Hi. So I'm a much older clinician, and I signed up for this to look at what you're doing just because I have been kind of beating my head into the wall to try and get something going. Does it have to be a technical thing? I can see from the eczema's presentation that not necessarily. It could be an idea that is very focused on a particular problem and just getting people to, so it can be anyone who can apply for these fellowships, because I have no experience whatsoever in biodesign, but I do have a very specific problem that I've been chasing all my career that I have a solution for. So I've been reluctant to even try for this fellowship just because of how naive I am about all these things that you guys are presenting. How much support and how much experience do you need to apply for this fellowship?
Great question. So you don't really need a background in this. The idea of the fellowship is really to teach the process. In fact, even people that necessarily might have a background, you have to tell them to kind of leave what their preconceived notions are behind to start from the clinical need and moving up. And there are people that come in with a project or an idea that they want to work on. However, I do urge everyone, and we start with essentially clinical needs finding and looking at different opportunities, different needs, and investigating all the smaller components of it to understand and triage your needs to find the right one and fine tune it first. And same way, trying to stay solution agnostic in the early half of the fellowship so that you can actually hone in on the need is key. And so to answer your question, you don't need experience. The idea is that we're teaching people how to go through this process, not that they have a background before. And many of our fellows did not have any background in biodesign before joining the fellowship. That's what's, I think, really unique about it.
And I see most of the participants are mid-career. I'm a kind of a late career kind of person.
I think that that's also completely fine. Everybody starts innovation at different time periods. We actually see kind of a mix often in who joins. Sometimes it's people that are early career and then late because that's when they have the time and leeway from their other clinical responsibilities or other faculty responsibilities. And so we do see a little bit of that dichotomy as well. So it's not a specific time period.
Thank you.
Thanks so much for these questions, and Kunj, thanks for that. Another question, maybe about the biodesign process, Kunj. How do you conduct the needs finding to ensure it's thorough and inclusive? That may be a broader question, but hopefully short response.
It's a bit of a broader question. And so, but essentially the idea with clinical needs finding, it doesn't have to be that you have gone to every clinical space per se. But the idea being that you want to step out of your clinician hat, especially if you are a clinician, and just be an observer. And we encourage you guys, the clinical needs finding period is in October, November, December, and taking different opportunities in different spaces, outpatient, inpatient, procedural, clinical, so that you get a feel for a lot of different needs. And then a lot of the steps after that is more about investigation and research into those potential needs or shortcomings that you're seeing when you're observing. But it's I think something that, especially in this faculty fellowship program, that we encounter is, everyone is an expert in their field or in their space. And so kind of stepping away from a lot of preconceived biases and then putting on a innovator hat and doing needs finding is what we really work on teaching.
Awesome. Thanks so much. And then the last question that I see is regarding interdisciplinary collaboration, probably another biodesign question, Kunj. How is interdisciplinary collaboration encouraged, and is there a mechanism for time, people, and budget management?
So interdisciplinary collaboration, I would say that we generally have, this fellowship is open to both engineering school and to the School of Medicine. And so that provides opportunities for collaboration. We also have our full-time innovation fellows. There's about 12 a year that come to a lot of the clinical or the needs showcase. They come to brainstorm with the faculty. And so sometimes that has started a opportunity for collaboration. And then we also have engineering coaches that are assigned, that are external to Stanford, but have been involved with many projects. Many of them are innovation fellows from past years that are assigned to you as an engineering coach during your prototyping and development of concepts. So those are kind of some direct opportunities. We don't require that everyone be a team per se, because we've recognized that in the faculty, many have their own things that they're very passionate about, but there are some inherent or organic creations of teams between the BFFs that sometimes, I personally feel like teams allow for a better path forward. And you'll see that a lot of our presenters today have teamed up with others, and myself, I've done a similar thing, because it's hard to, this is something that is hard to do alone. And I think collaborating and understanding that this isn't a secret where this is my work and I don't want to share it with others. I think that is probably the biggest pitfall. And so that's really over and over again told. There's not, in regards to kind of mechanism for time, people, and budget management, I'd say, but like those are more for projects that are coming out of BFF. And that's something that goes into applying for many of these funding opportunities. The time of the engineering coaches and other consultants, that's all kind of part of the BFF program itself, but obviously that's not an endless amount of time. That's like to get the initial working and guidance.
Excellent. Thanks, Kunj. I think those are all the questions, unless anyone has anything else, but this has been such a wonderful presentation and so exciting to see all the really great opportunities that are being put forth and all the great success that's also happened in tandem there. So we look forward to the next class of MCHRI fellows that can be supported through the BFF program. Please keep in mind, we do support up to 6 slots. We just announced the call for that. So as you apply, the biodesign program does make us aware of that. And then if you have any questions or additional questions, there's going to be the wonderful in-person info session at the Clark Center later this week. So thank you again and hope everyone has a great day.